So what I want to talk about is how we have shifted the focus in the NHS to look at quality in England, the context. I want to give you a little bit of background on Greg Dyke's quote, which I learned at a seminar of his when he was talking at a seminar I was at about follow the money and the new approach. So that's me. I like collecting degrees. It keeps me entertained. But this is the mission for NHS England. High quality care now for all and for future generations. And there's some really, really key messages in that simple statement. I use it, liken it to when Kennedy walked into the NASA Space Center and he asked a cleaner, "What do you do?" And he said, "I help put people on the moon." I would like it if somebody went into a GP surgery and was a receptionist was asked, "What do I do?" And I would like that receptionist to be able to say, "I help provide high quality care for all." We all make that contribution, and we're lucky, I think, in the NHS that it's a universal health. I think it's an immense privilege for me that I've never, ever, ever, ever had to ask anyone whether they can pay for their care. But for future generations is how do we make this sustainable given the challenges we face? And Darzi took the definition of quality a stage further in his next stage review and talked about clinically effective, safe care with a positive patient experience. And the domains in NHS England come from that because we split effective into 3 further domains: reducing premature mortality, enhancing the quality of life for people with long-term conditions, and helping people to recover from episodes of ill health or following injury. And we are endeavouring to measure our progress against those 5 domains. Now, what would that mean for people? Well, it would mean that people feel supported, that care is organised around them, that they will feel given as much control as they want. Self-care is not abandoned care. And that they will be treated with compassion, dignity and respect. We've had the scandal of mid-staffs and Winterbourne View, and it is shocking and horrifying to live in a system where you think that can happen. That people will feel safe and that we will listen to people and use that feedback to continue to improve the service. And I was at a lovely IHI seminar recently where in the UK where somebody talked about three types of measurement. There's measurement for research, which is essential, vital and really important, but is inapplicable in the real world. There's measurement for judgment, which we're really, really good at in the NHS. That's a sort of annual, have you hit your target? And then there's measurement for quality improvement, which is a completely different sort of measurement, which should be owned by local teams, local organisations and systems, and is regular, frequent feedback to help people improve the quality of their care, and is not used for judgment, and is not applicable, truly applicable to research. So what are the challenges? I think this can be either portrayed through the lens of this is a disaster, or we could actually celebrate the success that people are living longer. Hoorah! And we've got to remember that the vast majority of people now are living up to their 80s in quite good health. We can do more for people. I remember when I started off in medicine, the limited formulary I had in the 1970s to apply for treatment for people. I learned that testicular cancer, seminoma, somewhat awful, teratoma, terrible, I think was my acronym for remembering it. Appalling survival rates. The survival rates now in the upper 90% for those 2 cancers. We can do more and more for people with machines that go ping. And society's expectations have changed. I think we have a shift in the 20th century. I was the expert, the repository of knowledge, the guide. People came to me because I knew about medicine and healthcare. As I said to a bunch of MPs from our own parliament recently, I shouldn't have said this, when you send me a question, I just Google the answer. And we have a problem now, which is the economy has tanked in the UK, and public sector money, there's no growth. And we know that healthcare growth exceeds that of normal inflation year on year. So we've got this emerging gap between funding, and if we carry on doing what we've always done, we're going to be broke very quickly. We also have in this context the emergence of long-term conditions as part of our success. So the 20th century was about disease, trauma, famine, plague, whatever you like, war. The 21st century is about long-term conditions. It's estimated that 70% of all health and social care costs in the NHS and social care are now consumed by long-term conditions. And I think these following slides illustrate that. This is not from the Scottish study, but is from the Somerset study, but replicates the results. So we now have 2 studies showing exactly the same results, that long-term conditions now hunt in packs. And our single condition approach to disease management is erroneous. Our research, which is based on studying single conditions and excluding anyone with comorbidities or anyone over the age of 65, kind of makes the evidence difficult to apply to the actual population we're trying to treat. And this, taken from a BMJ article in 2009, I think amply illustrates the sort of problem. And if you actually listen to people who we are managing, treating, supporting, navigating through the system, our system in the UK is hugely fragmented and difficult to manage, and they have to invest a huge amount of time and personal effort to get a good quality outcome from it. And this is taken from work done. This was just doodled on at a seminar like this, and a woman doodled what her life was like with long-term conditions. So the orange marks are the consultations with healthcare. The blue line is her experience of her long-term condition. She's the one living with it. She's the one who's expert. And there are always 2 experts in the room with long-term conditions, the professional and the person with the conditions. And this is taken from someone whose husband had Alzheimer's, Malcolm and Barbara, and this is their experience of the web of care. Hugely, hugely complex. And again, they had to invest a huge amount of time and effort in managing that. And bits of it were fantastic, and bits of it weren't. So I think we need to move beyond the way I was trained to think about the inviolate relationship between the patient and the clinician, and stop putting our hands in the faces of carers. They are a huge asset in the management of long-term conditions, and also what the community that people live in. How can we mobilize those assets? We also need to reorientate the way I was trained. I did a presentation yesterday about patient activation, the work by, I think it's Julie Hibbard, in the States, a 13-point questionnaire which tells you what level of activation the person has in front of you. This reminded me of the story about Ken Dodd, go with me on this one, who, when he started off in his career as a comedian, he would sit a colleague, someone he employed in the audience, to measure the audience response to his jokes and also to record who was in the audience. As a result, allegedly, he now tells 3 jokes at the beginning of his set. From the audience response to those 3 jokes, he knows what the audience is like, and he then frames the rest of his set to suit the audience in front of him. Now, I was never trained to identify what is the level of patient activation of the person in front, or activation of the person in front of me, and then how do I tailor my consultation to that person so I maximize the effectiveness of my consultation. And I think that's a really important dynamic we need to get into. So I think the soft stuff is the hard stuff. I think it's already been mentioned. This is about culture eats strategy for breakfast. And if we don't really try and understand the mindsets and beliefs of people, individuals with long-term conditions, of the professionals, the values they bring, and their needs, met or unmet, and we systematically try and address those, then any of our changes will fail. Human beings, it was Chris Ham who said that the health system in the UK, the NHS, is an inverted pyramid of power. It is not the chief executive who makes the decisions, which commits resources. It's the professionals on the front line. Unless we respect and acknowledge that and engage and involve them in the decision making, in the system we are designing. So my belief is I need to try and support the creation of a system which supports professionals to do what I know I wanted to do on a daily basis, which was to deliver outstanding care. And any failures were in part due to the system and occasionally due to me, but my lawyers have told me not to go into that. And I think this is about changing the nature of the conversation right at the front line. Greg Dyke talked about following the money, and as a clinician, this has always been a bit hard for me. Why should I be interested in money? Once I realised that delivering value is about quality divided by cost. Porter and Teesberg have obviously highlighted this with their great article in the Harvard Business Review and their book, which I read and then realised I might as well have just read the Harvard Business Review article. If you actually follow how money is spent, we realise that there is a huge association of spend with demographic now. But actually the interesting thing is, this is not because of age, it's because of the long-term conditions. So if you don't have long-term conditions when you're 80, you don't cost a lot. It's not the age which drives it. And in fact, if you're 55 and you have 5 long-term conditions, then you will cost as much as anyone in their 70s or 80s. It's just the fact that old age is now associated with multiple long-term conditions. And there was a very interesting analysis, which I don't have the slide for, which shows there's a bimodal curve in cost distribution, because we actually neglect the fact there's a huge cost at a younger age group because of disability and serious mental illness and substance abuse. Long-term conditions hunt in packs. This complicated graph is from the Somerset project, where they analysed episode treatment groups. And if you go halfway down, you'll see there's diabetes, 5,676 patients with diabetes. Only 829 had diabetes alone. Now, some of those conditions are synergistic. You might expect them to be associated with diabetes, ischemic heart disease, hypertension, but some of them aren't. COPD, arthritis, mental illness. And we need to, I think we're just at the cusp of learning how to develop a taxonomy, an insight and understanding for comorbidities. And we've challenged NICE to actually come up with guidance for comorbidity management. The cost, as I said earlier on, there's a cost associated with age, so we know that, but actually the real cost is associated with the number of long-term conditions. And this is from the Year of Care study. The last two, we're into the third year. We've got some pilot sites which are tracking annual costs through health and social care and looking at what the implications of that are. And as you can see, what we found, interestingly, is if you exclude Alzheimer's and serious mental illness, there's a suggestion, and you know, this is not firm evidence and more research is needed on this. There's a suggestion that you just need to count the number of long-term conditions to develop an annual cost. So you can perm any 3 to 5 long-term conditions, and that will give you the cost for a year. As you can see in this, the costs go up dramatically, but you can also, we've looked at the setting and the big sort of the crimson bar at the bottom here. You can see the primary, this is from Somerset again, the Symphony project, this data is published. You can see that primary care costs go up, but there's a massive escalation in inpatient costs, a degree of escalation in outpatient costs, mental health, and social care and community care. So we're starting to get a handle on how can we analyse the costs in the system and perhaps develop a new formula for funding the system. So we also have looked at the difference between risk stratifying our population using one of the common risk stratification tools and just counting the number of long-term conditions. And actually, interestingly, and this is not an either or, there may be a bit of both and here, they do different things, or they tend to pick out different cohorts of patients, so that risk stratification identifies the crisis curve. So those patients who are going to enter a crisis, but then you'll get regression to the mean. over the next 3 or 4 years. And this is one of the big traps that people fall into when doing analysis of coordinated care and things. They say, oh, we've taken this cohort of patients with COPD and costs came down within 3 years. Well, that's just regression to the mean. You need to have a control group or look at the whole population impact if you're to avoid that trap. But what we found, if you count the number of long-term conditions, what they tend to do is predict escalating costs over the next 3 years in the community and acute care. Again, take this with a pinch of Siberian salt mine, because some of these are small numbers, and I wouldn't say this is research data, but it sort of kind of signals where we should be looking. Left-hand side, both groups here, both cohorts, risk stratified, but the left-hand group were not known to an integrated care team, and the right-hand group were known to an integrated care team. And you can see that the locus and focus of cost shifted from the acute sector into community and social care over 3 years. And that's quite interesting as well. What we're trying to understand is, well, does that actually save any money? And I don't think I would stand up here and put my hand on my heart and say it saves money, but I would say that it increases value. If you take the definition of value as quality divided by cost, there are 3 ways you can improve value. You can improve quality while maintaining cost, you can maintain quality while reducing cost, or you can have the holy grail, which we're all looking for, which is increasing quality while reducing cost. And I had an argument with the director of finance a few years ago where he said, what's the point in investing in palliative care services in nursing homes? I'm not going to see any reduction in cost that we pay for people having their treatment in hospital. And I just looked at him and said, where would you rather die? An acute medical ward or in a residential care home where people know you? And he went, oh yeah, I get your point. And we need to understand, we need to, I think, measure value as much as we just measure cost or quality. And this I took from Greg Dyke. I worked with the same director of finance and said, we tend to look at organisational costs. What's the cost from a patient's perspective? And he said, well, we've got about £1,825 per patient to invest in Lincolnshire. I'll have a look at where we're spending it. And I rounded this up because I can't do maths. So I said we've got about £2,000 per head of population. About £200 of it goes into primary care, £500 into community and mental health, £1,000 into the acute sector, and £300 into specialised commissioning. If the acute sector goes up by 4%, and I think this is really important because we talk about percentage increases and everything in the hospitals, but we need to understand the gearing in the system. What are the implications then if you've got flatline funding for the rest of the system? If you have, and this is for the NHS where funding is capped. Well, what it means is we'd need to take 20% out of primary care to continue to sustain the system. Do you remember I said at the beginning, high quality care for all now and for future generations? This is about the future generations. Now, of course, that would never happen, would it? Except 10 years ago, the NHS share of investment in primary care was 10%. As of 2011, it's 8%. Do the maths, it's already happening. The other gearing in the system is that an acute hospital probably serves a population of about 300,000. A general practice in the UK, the average size of general practice is 6,500. So one general practice improving is going to have diddly squat impact on an acute trust. And that's why one of the strategic characteristics we've said for the new system in NHS England is we need to build primary care which works at scale, which means that we need a primary care which is coherent, consistent, and has a common purpose at scale if we are to really change the system. If we do that, and we integrated that with community and mental health services, then what might the impact be? Could we safely disinvest 4% in the acute sector? And back home when I do this presentation, people sort of go, actually that sounds feasible. But it's understanding at the macro level, what are the sort of, what's the frame we need, the lens we need to look at this through to make the change happen. You may have noticed I haven't mentioned any disinvestment or touch specialised commissioning. I've been doing specialised commissioning for over 10 years, and I've never got any money out of that. It's just it's too small numbers, high cost, but also high political impact, trying to disinvest in that area. Actually, that's not entirely true. You can disinvest, but it's risky. You also need to think about public health, the real upstream. We've got primary and secondary prevention, social care, and we've invented these things called health and wellbeing boards in local communities where the clinical commissioning groups, the area teams from NHS England, Public Health England, and the local government come together to look at the needs of their local population and decide how to configure services. That's the theory. Unfortunately, it involves human beings, and so the actual reality is somewhat different. The other thing is that in terms of activity, what we tend to look at, I was involved for quite a few years in referral management, because obviously the major activity going into hospitals are referrals. It's over 50% of activities, both first outpatients and follow-ups. And so logically you'd look at that, because if you can reduce that activity, you'd reduce the cost, wouldn't you? But if you look at the relative cost of outpatients, you'd have to take a huge amount of activity out of the system to have any financial impact. So where's the big cost driver? Emergency admissions. And what are emergency admissions predominantly due to? Failure of long-term condition management. So if you look at the Kaiser mantra, which is every emergency admission is a failure of the system, I think they're absolutely right. Of course, trauma, surgical, you can count. But when I was stunned when I looked at the analysis of bed occupancy in Lincolnshire, and 15% of emergency beds were occupied by people over the age of 85 who took up 25% of all bed days. So a very small part of the community. So I think it's about reorientating people. You know, I think in healthcare we only have 4 service lines. Here's something controversial. We provide access for people with dis-ease, and we help them understand. We either put them back at ease, or we put them into one of our other service lines. We support health and well-being, and that's primary and secondary. So we can point someone who has dis-ease to exercise, stopping smoking, reducing their weight, reducing their alcohol consumption, and working with local authorities to do that. Or we can do sort of secondary prevention, so screening, immunisation, starting statins, things like that. I think then we have planned care, which is you have something wrong with you which requires a finite solution. And I think activity-based funding and tariff and everything is great for that. Get a HIP done, cost it, have choice, wonderful. But the big service line is you don't have disease, you actually do have a disease, and it's a long-term condition. How can we work with you to understand what your goals, your ambition is, to help you manage that so it has the minimal impact possible on your life? So, I think we need a new system approach. Back in 1990, when I left surgery and went into general practice, which I can tell you was like going from England to Japan, the culture shock was quite profound. I had to completely reorientate my brain as a clinician as to the job I was being asked to do. There was a gap between the GP and the specialist, but it's nowhere as big as the gap that exists 25 years later. I've told this story before, so apologies to you, those of you who've heard it, but my wife sustained a depressed tibial plateau fracture a couple of years ago, and I rang a mate when we got back to England from the skiing holiday and explained to her what had happened, and she's a knee surgeon. Would she help me get it fixed? Would she fix it? And she said, well, I'll help you get it fixed, but not me. I only do planned knee surgery. I'll get the acute knee surgeon to see your wife. I knew that they'd gone down, just specialising in joints, but I didn't realise that they'd even further subdivide their speciality into acute and planned. And I think the problem is that the specialists have become more and more specialised. this refers particularly, this challenge I think is in particular for the medical profession. And we've clung to the hospital because of its status, its white coat, its privileges and everything, and makes us feel very important and very rich in many cases. GPs have had to carry on doing what they've always done. Care has become more complicated, and more work has been loaded onto primary care. But what's happened is there's been an eruption of complex care in the community. And I think I was reflecting on this recently, we've tried to plug that gap with, in the UK with Evercare, community matrons, and even virtual wards. And it just hit me recently when I was listening to the description of the extensivist model in the US, that we'd missed one profession out of this solution, which was the medical profession. So GPs stay doing what GPs doing, specialists have moved further to the right, and there's a whole cohort of complex care in the community which ends up, by default, going into hospital because we know how to risk stratify the population, but we haven't risk stratified our services. And so I've called this the care gap. I recently went to Newark and Sherwood CCG, and they in 3 slides, and I've got a couple of them here, looked at, okay, if we risk stratify our population, what are the services we need to have in place to meet the needs of that population systematically? And they set up, they decided that they needed to shift their care from the traditional model towards a community base, but they had this sort of, in the middle here, this community care, consultant-led services, specialist teams. And it was looking at this some months later, I realised that actually, perhaps what we need here are complex care practices. And I've talked about this back home. There's a great deal of interest in it. I've also discovered that some of these already exist in the NHS, are doing great worth. But what we're not very good at doing is measuring nothing happening. And we're not very good at tracking value in the system so that what is the impact of primary care, complex care practices in the community, and tracking that impact right through the system so we can illustrate their benefits and potential. National Voices a year ago, or over a year ago, was commissioned by NHS England to ask, well, what do people with long-term conditions want? And what they said is, after an extensive consultation, my care is planned with people who work together to understand me and my carers, put me in control, coordinate and deliver services to achieve my best outcomes. Which condition does that refer to? So the public's perspective is they're not interested in a condition-focused model of care. They're interested in a person-centred and coordinated model of care. And taking evidence from England, based pretty much on the Wagner model of chronic disease management, working with wonderful people like Sue Roberts, Alf Collins, Simon Eaton, and others, they've come back and said, on the work we've been doing, we think there's four key components that should be in place. One is we need to have engaged, informed and empowered individuals and carers. We need to use the evidence around best organisation and clinical processes. We need to have health and care professionals working in partnership. And we need to use commissioning to create the right framework to enable those other 3 components to be in place. And there is no magic bullet for this. No one component on its own will do it. And that's why we've used the metaphor of the house of care. At the centre of the house is person-centred coordinated care. The pillars are engaged, informed individuals and carers, healthcare professionals committed to partnership working. The roof, we draw down from the roof all the best evidence we have, and we use commissioning, and we use it as a quality improvement cycle to continually evaluate, plan, do, study, act in a continuous process to improve the care for the person at the centre. Take away any one of those components and the house collapses. And the house supports what I think it was Julie Hegarty talked about, continuity of care. And 3 really big components which I've seen in all the integrated care systems I've been to. The first and most is informational continuity. The information about me is with me wherever I am in the system. And my personal belief is let's give it to the person. So often now I've seen that where we've actually transferred ownership of the medical record to the individual, it's had a powerful impact in empowering them, but also improving continuity of care. Management continuity, levers and incentives which support continuity, and relational continuity. There is someone I can turn to who will help me navigate the system and be my guide and advocate in managing my care. The House, I believe, supports all those components that National Voices said people wanted, and these are taken from the National Voices consultation. But also, interestingly, I recently discovered some work which had been done by Monitor on economic evaluation of impacts in care, and I got this incredibly clever clinical fellow and sent him off to look at the 300 slide deck, and he came back and said, if we implemented the House of Care, then potentially, and again, this is the maximum potential, so take it with a pinch of salt, we could reduce cost in the NHS, reduction of admissions for common LTCs, and look at the top two, especially frailty, which is a diagnosis, not an adjective, by the way. John Young, the NCD for Integration and Frailty, if any of you haven't read it, his BMJ Christmas article a few years ago caught my eye at the time. I didn't know him then, I know him now and think he's wonderful. And he said, what's the definition of frailty? You can't walk faster than the Grim Reaper. Reduce the use of low-value drugs, shift activity. I mean, we've got thousands of pharmacists in the UK, and we don't use them to best effect. Empower people in supportive self-management. We just know from all the stuff done by, oh gosh, I've just had a moment. It'll come to me. The big report about how, where Wanless report, that actually we needed to get upstream, and that would produce massive benefits to the NHS and also safety. So this comes back, I think, to Kathy's point. So I say, and this my personal experiential learning, we should only do at a national level what can, should, and could be done at a national level. So create an enabling framework. It is down to local health economies to really design, to understand, because as I say, that in the UK, Barnsley, Birmingham, Basingstoke and Barnstable are four completely different places, and trying to impose the same solution on those four places is insanity. You need to understand the culture there, the people there, and how they work together. But the House of Care has to be built. The only place the house can be built is that professional interaction with individuals with long-term conditions, and we need to respect that and work out how to best support it. NHS England's just published its business plan, or its planning guidance for 14-15 and onwards, and a 5-year strategic framework. And we've been doing a call to action across England, talking to people, and we see that there are 6 key characteristics for the system going into the future. 1 is empowered citizens, 2 is primary care at scale, 3 is modern integrated care, which we can talk more about, 4 is urgent care, elective care, and specialised services. And I think the future, I took this from David Levy, who's one of the regional medical directors, is currently our system looks a bit like this, big gaps between everything. I think we're going to have to shrink the general hospital and its footprint. I think we're going to have to centralise specialised services. I think we're going to have to build primary care. We're going to have to integrate it with community care. We're going to have to understand the benefits and value of investing in social care. And in 2015-16, the NHS will transfer, well, what was planned was £3.8 billion of NHS money to work collaboratively with social care in local governments. It looks like that figure is going to be in excess of £5 billion because people want to go further, faster across local health communities, health and social care communities. And I think we need to bring the assets that patients bring to the system into play if we're going to build a future healthcare system which provides high quality care for all now and for future generations. So I go back to my hero, William Osler, who said that the good physician treats the disease, but the great physician treats the patient who has the disease. Thank you very much for listening to me. I look forward to your questions.